One of the special situations that headache medicine doctors like you face are headaches in females, especially menstrual headaches and
Mhm.
headaches during pregnancy. Can you tell us what is your treatment approach for these two types of headaches?
Sure. So I think you make a wonderful point because in general, migraines affect young females disproportionately more than anyone else. And that is the most functional time of our life, right? We are getting married and having children and establishing ourselves in our careers. So you can appreciate this is the time where we really can't afford to have so much headache interfering. So I think aggressive intervention early on in terms of prevention with contraception planning on board is really important. So actually, whenever I meet with a patient in their childbearing age, I always try to discuss with them that do you have any game plan for pregnancy in the near future? Are you on contraception now? And how can we ensure that we've selected an agent that would be safe with the game plan of watching out from that agent? For example, if you're planning to conceive in 2 years, we try to choose safe options during this conception period and pre-pregnancy planning. But of course, in general, I'm lucky because most headaches improve during pregnancy, especially after the first
Oh,
trimester. So most of my patients will come back to me once they've started lactating, for example. But of course, those patients that unfortunately continue to have headaches through pregnancy, we do offer them therapeutics, including nerve blocks and safe medications in pregnancy. And really, that's a discussion that we have very closely with them, the benefits and risks of treatment during that time. I think your last question was about menstrually related migraine, and that's a very predictable kind of migraine. And we can cater therapies that are called mini prevention around that therapeutic window where we know predictably that's a trigger or that's a reliable time that migraine is coming. So we can schedule therapeutics such as a triptan 1 or 2 days before the period begins, continue it throughout the period, and allow them other therapeutics if they need it during that time. So again, the goal is to keep these patients functional and living their lives. So
Yeah.
absolutely. Is there any data on what the hormone is that is causing these premenstrual periods?
yeah, usually we blame estrogen, but
We
the
love to blame
abrupt,
estrogen, don't
yeah,
we?
abrupt withdrawal of any of the hormones.
Yes.
We see this again in the perimenopausal period between the
Mm,
ages of 45 and 55. We call that a perimenopausal dip because migraines
mm,
go again haywire and really it becomes unpredictable. And many patients get very concerned because their headache pattern is changing and evolving. Many of them get repeat MRIs even because we're so concerned about them. But again,
mm.
generally we say we should outgrow migraine without aura after menopause, for example. So I think the fluctuations of hormones is probably the biggest trigger for all of
Mm,
these unfortunate females that are affected with migraine in this way.
mm.